Okay, is it clear for you?
Yes, crystal clear.
Okay. Assalamu alaikum and very good morning to you. So today we'll continue with the hepatobiliary system, and I will touch a lot about the applied anatomy for these important subject in surgery and in anatomy. Okay. The liver. Okay? These are some of the functions of the liver, which all of you must know very well. So the main function is to produce and secrete bile in a rate of about 40 milliliter per hour. And it metabolites carbohydrates, fat, protein, and filtration of blood. I will rush on this. Remove bacteria, foreign particles, heparin synthesis and detoxification, and also it produces bile pigment. So the bile actually is produced by the liver and stored in the gallbladder. Okay. So what is the liver? It is, as you know, it is the largest gland in the body, not organ, but it is the largest gland. The largest organ is, is the skin. Okay. And it is in the upper part of the abdomen. It is highly protected by the costal cartilage and by the diaphragm. It is soft and pliable, well protected, and especially by the right costal margin. And anything in our body which is so vital, it needs to be protected. This is a fact in human body. Whenever you have valuable things, you need to protect these things. If you have a very expensive jewelry, you need to put it in a box. The brain is protected by the skull. The heart, lung, great vessels are protected by the thorax. Everything in our body, which is so vital, needs protected. The same goes for the liver, because it is very vital and highly vascular, so need to be protected mainly by the costal margin. And it is in the right side, but also it extends to the left to reach the left hemidiaphragm. As you see, this is the right lobe. This is the diaphragm is two domes. Each dome, we call it hemidiaphragm. So it reaches the left hemidiaphragm, as you see here, by its left lobe. The visceral surface is irregular. Okay. And this falciform ligament, which attached the liver to the anterior abdominal wall, can divide the liver into a big lobe, we call the right, and a little bit smaller, which is the left lobe. Okay, by what? By the falciform ligament. This is the falciform ligament. Okay. This is the visceral surface of the liver, and the right lobe, now this is the right lobe, and this is the left lobe, can be subdivided into two lobes, the quadrate and the caudate. Okay, the quadrate and the caudate lobe. By what? By the what we call it the H shape, an important structure here, forming an H shape in the visceral surface of the liver. As you like to, in Malaysia, you call it H shape. Huh? I don't know from where you get this H. It is H since millions of years, but when I reached Malaysia, it changed from H to H. Anyhow, so this S shape is formed mainly by four important structures: the inferior vena cava and the gallbladder, and here we have a fissure for ligamentum venosum and a fissure for ligamentum teres, forming this. The horizontal line for this H shape is mainly the porta hepatis. Okay, so the H shape divide or subdivide the right lobe into a quadrate loop and a caudate loop by the, I will repeat, H shape. These H shape, the limbs are the inferior vena cava, the gallbladder, two fissures. One fissure is allocated for the ligamentum venosum and another fissure for ligamentum teres. You will find, you know, that the circulation actually in the fetus embryo is totally different from the circulation in the adult. So many things that has been used in the embryo is no more being used in the adult life. When we grow in this miserable life, all the things that, most of the things that in the embryo is no more being used. So it changed to ligaments, okay? Like the lateral umbilical ligament, the medial umbilical ligament, anyhow, okay? So here, I will not enter into details of these ligaments. So the H shape is an important landmark in the visceral surface of the liver. And the liver is encapsulated by a fibrous capsule, okay? It is partially covered with peritoneum. All the liver is covered with peritoneum with the exception of this part. We call it the bare area of the liver, which is devoid of peritoneum. There is no peritoneum. Actually, this small part in the liver is stuck to the undersurface of the diaphragm. And there is no any peritoneum in this part. Actually, as I mentioned to you, and please keep it in your mind, there is no structure actually intraperitoneal structure. I will repeat, you will hear a lot that this is an intraperitoneal organ, this is retroperitoneal, but in reality, there is nothing called 100% intraperitoneal, apart from only one structure, or one, which is the ovary. The ovary is really in the peritoneal cavity. All other are just a name. We call it intraperitoneal because nothing actually inside the peritoneal cavity, only the peritoneal fluid. Okay? The porta hepatis, here is the porta hepatis. Okay, it is the heart of the liver or the hilum. Here is it. Everything, any structure leaving the liver or entering the liver is in the porta hepatis. I will repeat, any structure leaving the liver or entering the liver are placed in this heart of the liver, the porta hepatis. Okay, so it is a gateway to and from the liver. Where is it? In the posterior surface between the caudate and the quadrate lobe of the right lobe. Okay, here we will find the free margin of the lesser omentum. If you remember, you know, all of us, the lesser omentum connecting the lesser curvature of the stomach to the liver and exactly to the margin of the porta hepatis. Okay, in surgery we call it a duodenal ligament or hepatoduodenal ligament. In anatomy, we call it the free margin of the lesser omentum. Okay, here is very important structure in the porta hepatis. As I mentioned, everything leaving the liver and entering the liver are there. So we will find the hepatic ducts, the right and the left hepatic ducts, the hepatic artery, the right and the left hepatic artery, the portal vein. Here is the portal vein entering the liver. Here in the porta hepatis, you know the portal vein. I will talk later on about it. and the sympathetic and parasympathetic nerve fibers in the porta hepatis, and of course we will find a few hepatic lymph nodes. So these are the content of the porta hepatis. Okay, the relation of the liver, as you see, here is the liver, a big gland. You can see anteriorly, and these are the structure posterior. Anteriorly, definitely we will see the diaphragm, the right and left costal margin. I repeat, right and left. Why left? Because as you mentioned, the liver is so huge, it occupies the right quadrant and also it will reach the left hemi diaphragm. So you will anteriorly the right and the left costal margin, also the right and the left pleura, the lower margin related to the liver, the xiphoid process, and definitely the anterior abdominal wall. All these structures are related anteriorly to the liver. Posteriorly, you see now the liver is a little bit reflected above to show you the structure that's related posteriorly. Also, we have the diaphragm, again and again, the right kidney, the hepatic flexure. You know, we have two flexures, the hepatic and the splenic. So the hepatic flexure, or we call it right colic flexure, is posterior related. Of course, the duodenum, here is the duodenum, closely related to the liver. The intimate friend of the liver, the gallbladder, is not only posterior related, but it is stuck to the inferior surface of the liver. Also, we have the inferior vena cava, esophagus, and finally the fundus of the stomach. Some of the structures that are posterior related to the liver. By the way, relation in anatomy is very important to understand because we are going to use these relation in our career in the future, whether we are surgeon, whether we are any position. Because the definition of anatomy, actually, what is the definition of anatomy? Is, cut it short for you, is the study of human structures and the relation between the structure. If you don't say and, it is deficient. It's not a complete definition. So the definition of anatomy is the study of a human structure and the relation between these structures. Okay, the liver has many ligaments. Too many ligaments are attached to the liver, which is a two-layer of peritoneum from the umbilicus to the liver. Okay, and in its free margin, we have the ligamentum teres. Here is a ligamentum teres, which is actually the remains of the umbilical vein. So the umbilical vein in embryo will change to be the ligamentum teres in the adult. No more vein. It changed to ligaments. As we mentioned, the circulation in the fetus totally differ from the circulation in the adult. Okay. As you see, this falciform ligament pass on the anterior surface of the liver, then to the superior surface, and then it split into the right and into the left. Right, the coronary ligament, another ligament. Too many ligaments. What shall we do? This is anatomy. Okay, so it's split on the superior surface of the liver into right and left. The right forming the upper layer of the coronary ligament. We have two layers. We have the upper, we have the lower. So here is the upper layer of the coronary ligament. And the left form the upper layer for another ligament. We call it left triangular ligament. Okay. Here, sometimes we call it the right triangular ligament. So I will repeat: the falciform, which contains the ligamentum teres, ascend in the superior surface of the liver, then split into two layers. The right, we call it the upper layer of the coronary ligament. Call it the left triangular ligament. Okay. Still, here we mentioned about the bare area. This is the bare area. Okay, which devoid of peritoneum, lie between the superior layer or the upper layer of the coronary and the inferior layer of the coronary ligament. So this is the inferior layer of the coronary ligament, and this is the superior or the upper part of the coronary ligament. Ligamentum teres pass, this is the ligamentum teres, sorry, this is the ligamentum teres, pass into a fissure on the visceral surface, another ligament. Still, we have ligamentum venosum. As I told you, too many ligaments we have related to the liver. Ligamentum venosum, which represent the remain of the ductus venosus, here is it, ascend in the fissure on the visceral surface. Too many ligaments related to the liver, but actually they play no role or a very minor role in supporting the liver in its position. If you open the abdomen of any individual, you will find the liver is fixed strongly in its position. But these support does not come from these too many ligaments, but actually from the attachment, mainly from the attachment of the liver to the inferior vena cava by usually 2 or sometimes 3 hepatic veins. Okay, so keep in your mind that this support of the liver does not depend on these too many ligaments attaching to the liver, but usually is supported by the attachment of the hepatic vein posteriorly to the inferior vena cava. Okay. Another ligament is the lesser omentum. It's a ligament. Okay. And also it is omentum. Why we say omentum? Because it is related to the stomach. Any ligament related to the stomach, we call it omentum. So the lesser omentum is, as you know, from the lesser curvature of the stomach to the porta hepatis. Okay. So as I mentioned, I will repeat, too many ligaments, but they play no role or very minor role in supporting the liver in its coinoid classification. This is very important for you. Actually, in the undergraduate, I don't insist on these classification, but in surgery, you need to know that there is another classification for the liver forming, we call it coinoid classification, divide the liver into 8 functionally independent segments, as you see. 1, 2, 3, 4, 5, 6, 7, 8. It runs in a clockwise manner. Okay. Each segment has its own vascular inflow, outflow, and its biliary drainage. You can find the same segmentation in the lung. In the anatomy of the lung, we call it bronchopulmonary segment, as if the lung is divided into small lungs. The right lung has 10 bronchopulmonary segment, and the left has sometimes less, maybe 8. And each segment in the lung has its own characteristic, its own supply. So you can select one of these segments, whether in the lung or in the liver, because it is functionally independent segment. This is very important for you as future surgeons. Okay, so In the liver, we have the same. We have 8 functional independent segments. Each segment has its own vascular inflow and the biliary drainage. As you see here in the center of each segment, there is a branch of the portal vein, hepatic artery, and bile duct. So as if we have 10 or 8 small livers in each liver, okay? And the periphery of each segment, there is a vascular outflow through the hepatic veins. This is the coinoid classification, still in the segments. The numbering of the segments is, segment 4, sometimes we divide it into A and B. So segment 4A and 4B. And the numbering is a clockwise, as you see in this yellow arrow. Starting from 1, the 1 is posteriorly hidden. You cannot see now because it represents the caudate loop of the right loop. Okay. Segment 1, which is caudate, is located posteriorly. Then we have segment 2, 3, 4, 5, 6, 7, 8. What is the why we say it is important, especially for surgeon and radiologist, in the view of the need for an accurate preoperative localization of any lesion in the liver. Okay? So if you need to localize, especially preoperatively, any lesion, whether it is a mass, a tumor, a cyst, whatever, you need to know in which segment that you are going to deal. Okay, so now liver resection is now practiced widely with reduced morbidity and minimal depending on segment affecting the other, because each segment has its own characteristics. Okay, so we call it segmentectomy, or anatomical resection of segments for trauma, laceration, or tumor based on this coinoid classification. Okay, it's very important to understand this in your future career, inshallah. Okay. Another important part of this lecture is the blood circulation. Usually in any topics of anatomy, I don't start with blood circulation. I write blood supply, and the blood supply is the arterial supply and the venous drainage. But the story here is quite different in the circulation of the liver. So we mention blood circulation because not everything, all the vessels entering the liver are arterial. Mainly they are venous. So it cannot say blood supply, arterial supply. Okay? So the blood circulation, 30% of the blood entering the liver is coming from the hepatic artery. And as we know, the hepatic artery is a branch of the celiac trunk, okay, which divide in the porta hepatis into the left and the right hepatic artery, okay. The 70, about 70%. By the way, never mention a digit or a number in the human being without saying the magic word about. Okay, this is part of the professionalism. If you want to be professional, never mention any number in the human being without the magic number before it. What is the normal pulse rate? Is about. Whatever you add after about, it's correct. Okay, so, or at least you must give a range. That means you know what's going on, because this is the biology is the science of variation. There is no individual similar to other. So don't give a fixed number. About 70% of the blood entering the liver is coming from the portal vein. Okay, for that reason we say circulation, because the portal and the hepatic artery enter the bringing blood to the liver, but this blood mainly is not oxygenated. Only hepatic artery have oxygenated the blood. Happen in the sinusoid of the liver. We have, as you see here, two hepatic veins coming posteriorly to drain to the inferior vena cava. So the liver drain to right and left hepatic vein, which leave the liver posteriorly and drain to the inferior vena cava. Okay, so don't confused by the blood supply to the liver. We say blood circulation. Why? Because about 70% of the blood entering the liver is coming from the portal. As you see, this is the portal vein. And about 30% is coming through the hepatic artery, bringing oxygenated blood. Then 2 or sometimes 3 hepatic veins run posteriorly to reach the inferior vena cava. As I mentioned in the last lecture, in our abdomen, actually, we have 2 types of circulation. We have the portal circulation and we have the systemic circulation. This is the portal circulation. Is the outcome of the union of the splenic vein with the superior mesenteric vein behind the neck of the pancreas at the transpyloric vein at the level of L1. Then it will enter the porta hepatis. This is the whole GIT drain to the portal circulation, because we explain why it cannot enter directly to the inferior vena cava or to the systemic, because it contains a lot of toxic materials that need to be detoxified, get rid of it in the liver, then and only then the blood can enter the systemic circulation. And we have another circulation in the abdomen. We call it the systemic circulation, mainly by the inferior vena cava and its tributaries. As you see here, the iliac, we have the gonadal, we have the renal, we have the lumbar, we have the suprarenal. This, no harm. The blood can go direct to the right atrium and can be redistributed in. But the blood coming from the GIT cannot enter directly to the systemic circulation, because too many toxins we have in our drinks, in our food. We don't know what's going on until it reaches the liver. So I will repeat, we have 2 types of circulation in our abdomen. We have the systemic circulation, mainly the inferior vena cava and its tributaries, and also we have the portal circulation and its tributaries. The important thing is that there is important site for anastomosis between these 2 systems, the systemic circulation and the portal circulation. It is of crucial importance to understand and to know these sites. Actually, we have the major 4. Sometimes we have 5, but usually we insist on 4 portosystemic anastomosis. The first one is between the portal circulation through the paraumbilical vein and the superior and inferior epigastric vein. This is the first site here near the umbilicus in the inferior abdominal wall, between a paraumbilical vein, which belongs to the portal, and superior and inferior epigastric vein, which belong to the systemic circulation. Okay. The second porto or portal systemic anastomosis, you can say porto or portal, is between the superior rectal veins, which is portal, and the inferior and middle rectal veins, systemic, forming an anastomosis as you hear in the rectal area. Another important portal systemic anastomosis. We have another one here between the lumbar and renal venous system, which is systematic, and the colic veins, which is portal. Okay, we call it colic veins, belong to the portal systemic. Finally, we have the most important one, which is in the lower part of the esophagus. We mentioned something about this, between the esophageal vein of the left gastric vein, which is portal, and the azygous system through the esophageal vein, which is systematic. Okay? So there is a portosystemic anastomosis. Usually, all of us have these 4 important sites. Now, imagine that the blood which need to enter to the portal vein, to the liver, has some problem. Okay, there is some narrowing. There is some difficulty in entering the liver due to many reasons, like, let us say, chronic hepatitis, like cirrhosis, like chronic liver disease. Okay, need to enter, but there is a problem flow of the blood into the portal circulation. This is typically what we call it portal hypertension, which is an important sign in the mainly in the liver disease, chronic liver disease, portal hypertension. So the pressure inside the portal circulation is increasing, will be high. So this high pressure inside the portal circulation need to be relieved, need to escape from this high pressure. So what shall happen? It will go to these 4 sides because there is anastomosis between, as if it is a valve for escaping the high blood pressure to a lesser blood pressure, or to relieve the high blood pressure in the portal hypertension. So the blood is now shifted to these 4 sides. And you know that in the portal hypertension, what shall happen? It is what we call it the esophageal varices. Why? Because the blood is shifted from the high pressure to the normal pressure within the systematic. So engorgement, congestion of the veins at the lower part of the esophagus. Okay, this is what you call it esophageal varices. And also, this is what we call this? Yes.
Caput medusa.
Yeah, the caput medusa. You know, the medusa head is resemble the caput medusa. Why it occur? For the same reason. The blood need to escape from the high pressure in the portal circulation to the normal pressure in the systemic, and making this just like a medusa head, caput medusa. The same goes for the rectum. At the lower part of the GIT, the rectum is engorgement, congestion. So any touch to the, especially the esophagus, very minor trauma can lead to a disaster, and you can lose your patient because he or she might lose about 1.5 or 2 liters in at once. Okay, so this is the portal hypertension, the sign of portal hypertension, mainly due to chronic liver disease. Okay, so the surgical portosystemic shunt. What is the surgical? We, the butchers, the surgeon, sometimes we create a shunt between the portal circulation and the systemic circulation. The idea is to relieve the high pressure in the portal hypertension. So usually we can choose any vein, but usually we, as you see here, this is the splenic vein, which is portal, and we cut it and re-anastomosis with the renal, which is systemic. By doing this, it's a very troublesome operation, has a high mortality rate, and a really lengthy operation. Nowadays, what shall we do? Yes, surgeons.
We perform the tips.
Yeah, yeah. So now tips has revolutionized everything in the portal hypertension management. Actually, this is in our time. eh, we don't know about tips. This is 100 years before when we were medical students. It started in the early 19s. What we call it tips: transjugular, intrahepatic, portosystemic shunt. Done under local anesthesia. You can insert a catheter, you know this, insert a catheter through the internal jugular, and this will go to the heart. From the heart, you can take the inferior vena cava, and when you reach the inferior vena cava, you go through the hepatic. Of course, this is guided by a camera and guided by either ultrasound or CT scan, whatever. And you can now the inferior vena cava, and you can follow the hepatic vein and insert the catheter into the parenchyma of the liver, and you can leave a stent there. By doing this, you now do a portosystemic shunt. Very simple, very easy, under local anesthesia, and make a revolution in the management of portal portal hypertension. Okay. For that reason, we need to understand the anatomy. Eh? This is what you call it applied anatomy, which I do love in in my career. Okay, so this is the tips. The lymph drainage of the liver, you know, several lymph nodes in the porta hepatis all pass to the celiac node. But this is also important to understand. Few vessels from the liver pass through the bed area to the thorax, through the diaphragm to the posterior mediastinal lymph node. That means not all the lymphatics of the liver gone to the celiac node. We have a few vessels follow the bare area. If you remember, I said that bare area is stuck to the diaphragm, and through this bare area, some of the lymphatic travel through the diaphragm, and it can reach to the posterior mediastinal lymph nodes. Okay? Nerve supply, sympathetic, parasympathetic, mainly through the anterior vagal trunk from the celiac plexus. Okay? We mentioned about the liver support, some hints about the liver support. As we know, it is mainly due to the hepatic vein to the inferior vena cava. Too many ligaments, but play a very minor role. The main support of the liver is by this hepatic vein to the inferior vena cava. So the peritoneal ligament and the tone of the abdominal muscle play a minor role in its support. This fact is important surgically because even if the peritoneal ligaments are cut, the liver can be only slightly rotated. Okay, if you cut all the ligaments, the teres, the falciform, the coronary, the lesser omentum, still the liver is supported by, because mainly depend, just to keep it in your mind. Liver trauma. You know, it's a soft structure enclosed in a fibrous capsule. So you need to put this relationship of the liver to the lower lips. Always must be emphasized. Why? Because fracture of these ribs or a penetrating with to the thorax or upper abdomen can cause liver injury. And you know it is highly vascular, so it might lead to some emergency if you don't salvage the laceration of the liver. Okay. Also, blunt trauma from the accident are also common, and severe hemorrhage accompanies tears of this organ. It is protected, but protected by the ribs. So any fracture to the rib or the thorax can lead to tear in the liver. It's not easy to deal with the laceration of the liver, okay? But it's happened. Another thing is how to take a biopsy from the liver. You know, we have usually two procedures to do so. We have the percutaneous procedure. You know, you insert your syringe where, of course, or full expiration. Why? Another important thing to reduce the size of costodiaphragmatic recess and the likelihood of damage to the lung. Okay, so full expiration. Then you insert your needle through either the 8th, the 9th intercostal space where in the mid-axillary, of course, on the right side, here is the mid-axillary line. This is the left side, huh? So it should be in the mid-axillary line. You insert your, and you can now enter into the liver and take whatever you want, 1 kilo, 2 kg, 3 kg, whatever, okay? Where? Mid-axillary line at the 8th or 9th intercostal and full expiration. Full expiration, 8th or 9th intercostal, mid-axillary line. Or the same like tips. Nowadays, we call it transjugular liver biopsy. The same like how can we make the tips? We can also take a liver biopsy from the transjugular, or we call it transvenous. Okay, the same routes through the internal jugular to the hepatic, inferior vena cava, heart, inferior vena cava, then the hepatic vein, and you can reach the liver. Okay, let us go to the bile duct. It's a wonderful slide showing the whole bile system, starting from the hepatic, then the common hepatic, this is the cystic, this is the common bile duct, ending into the duodenum. So the bile duct, starting from the left and right hepatic duct, each coming from the loop. Okay. By the way, the caudate and quadrate, anatomically, they are related to the right loop, but functionally, they are related to the left loop. What does that mean? That means the secretion of the caudate and the quadrate loops, which are anatomically related to the right, is actually coming from the left. So we say anatomically they are related to the right, but functionally they are related to the left loop. Okay, just put it in your mind. So we have left hepatic ducts join the right hepatic duct to form the common hepatic duct. Don't be confused by these names. We have common hepatic duct, we have common bile duct. Okay, the common hepatic duct is the union of the left and right hepatic duct, unite after a short course to form the common hepatic duct. Of course, the common duct to form the common bile duct, or usually we call it the bile duct. Okay? So this is the common hepatic duct. It's about 4 centimeters in length and descend within the free margin of the lesser omentum. Another important I will talk about later on. Then we have the bile duct. It's about 8 centimeters in length, formed by a union of the common hepatic duct with the cystic duct. Okay? Ends, as you know, by piercing the medial wall of the second part of the duodenum about halfway down its length after joining the main pancreatic duct. Okay. The bile duct and the pancreatic duct join at the hepatopancreatic ampulla of water in the major duodenal papillae, and which is guarded by the, in surgery, we can divide into the bile duct into supraduodenal. This is in surgery, not in anatomy. Supraduodenal part, retroduodenal, infraduodenal, intraduodenal. 4 parts. Okay, the bile duct is about 8 centimeter. Supraduodenal, retroduodenal, infraduodenal, and intraduodenal. Okay, something about the gallbladder. It is a reservoir for the bile, as we know the bile. Please feel free to stop me, please. The host, who is the host, please feel free to stop me when time is over. Okay?
Yes, can proceed.
Okay. So the gallbladder, the main function is a reservoir. As we know, the bile is stored, or sorry, produced in the liver and stored in the, but it concentrate bile and excrete cholesterol and secrete mucus. We know that capacity of the gallbladder is milliliter, and the production of bile is 40 milliliter per hour. So how happened this? How come? Because the main function of the bile is to concentrate bile. Concentrate bile. The bile produced is a huge amount, but it is concentrated in the gallbladder until it is needed, and then the bile will be pushed through the bile duct to reach the duodenum. Okay, it's a pear-shaped sac lying on the undersurface of the liver. The capacity, as I mentioned, is about 50 milliliter. Can be divided into fundus, body, and neck. This is the fundus of the gallbladder, which is rounded, and it can project below the inferior margin of the liver, where the tip of the ninth costal cartilage. Then we have a body, is direct upward, walk backward, and finally we have the neck. This is the neck, which continues with the cystic duct. The relation, as you see, anteriorly, we have the anterior abdominal wall and inferior surface of the liver. Posteriorly, we have the transverse colon and the first and second part of the duodenum. This is the main important relation of the gallbladder. The blood supply, usually the main blood supply comes from the cystic artery, which comes from the right hepatic artery. The right hepatic comes from the common hepatic, which is a branch of the celiac trunk, and the cystic vein thrown to the portal vein. But this is not enough. Actually, there is, of course, you have done maybe, or you have seen many gallbladder cholecystectomy. When we remove the gallbladder from its bed, we will find many bleeding spots between the gallbladder and the bed of the liver. These are small arteries and veins run between the liver and the gallbladder. So the gallbladder not only take blood from the cystic artery. Yes, usually the main arterial supply coming from the cystic artery, but also it have some vessels running between the two structures because they are so close friends, the liver and the gallbladder. Okay. In fact, running to the cystic lymph nodes, and finally it will go to the celiac nodes, and of course sympathetic and parasympathetic. This is the cystic duct, which is a little bit about 4 centimeter in length. It's about connect the gallbladder to the common hepatic duct. This is the common hepatic duct forming the bile, and it's somewhat S-shaped. Some clinical notes to understand is very important. Actually, in surgery, you know that we call it, this is the area of variation. This area is the area of variation. more than 40–50% of the individual have some sort of variation in this hepatobiliary area. So error in gallbladder surgery are frequently the result of failure to appreciate the variation, these variation. It is important, therefore, before dividing, I will insist on this, before dividing any structure and removing the gallbladder, to have all the 3 biliary ducts clearly identified: the common, hepatic, the cystic, the bile duct. You should identify these 3 biliary ducts before removing anything, because you might lead to a serious iatrogenic problem. Okay, not only that, but also you need to localize the cystic and the hepatic arteries. Where you can find the cystic artery, you know, it is in the colored triangle. This is the colored triangle. You know, the colored triangle forming by the cystic duct, the common hepatic duct, and the inferior edge of the liver. Okay, so don't forget 3 biliary ducts, the cystic artery, and the hepatic artery. Why? Because usually a lot of variation, as you see here, a very long cystic duct, or there is no any cystic duct, or bifurcated gallbladder, or some artery are imposed anteriorly into the cystic duct, which is unusual. So you ought to be very careful. So the message here, always recognize anatomy before doing any surgery. Okay, why? Because simply this is the area of variation. Here is if you face hemorrhage from a cholecystectomy, and this can be controlled by what you call it Pringle maneuver. You heard about Pringle maneuver, of course. What's Pringle maneuver? This is Pringle maneuver. You know, as we mentioned, that this is the free edge of the lesser omentum. The free edge of the lesser omentum has the 3 important structures: the hepatic artery, the portal vein, what we call it in surgery, duodenal ligament or hepatoduodenal ligament, or the free edge of the lesser omentum. This is the lesser omentum connecting the lesser curvature to the. So if you face a hemorrhage, whether in the gallbladder, whether in the liver, whatever. So if you put your finger as this in the foramen of Winslow, do you remember foramen of Winslow? Epiploic foramen between the lesser sac and the greater sac. You can press because as we mentioned before, the main circulation to the liver comes from 2 sources, the portal and the hepatic. So you can press by your finger or a hemostat, temporary hemostat, on the main blood entering to the liver. By doing such, you are controlling temporarily the bleeding. And by releasing your finger or the hemostat slightly, you can localize exactly where is the bleeding spots. And you can do whatever you want. You can manage accordingly. So Pringle maneuver is using the finger or hemostat by pressing on the free edge of the lesser omentum, because we understand by studying anatomy that all the blood supply, all the blood circulation entering the liver come through these portal vein and the hepatic vein. So if I press here by anyhow, I can temporarily stop the bleeding, and then by releasing gradually, I can localize exactly where is this is what you call it a Pringle maneuver. Okay. So as we mentioned, gangrene of the gallbladder is rare. Why? Because even the cystic artery become thrombosed, like in cholecystitis, there is a rich secondary blood supply coming from the liver bed. Okay, so always keep in your mind that the gangrene of the gallbladder is rare because it not only take its blood supply to the cystic artery, but also, as we mentioned, from the bed